Hello, I am Dr. Bansi Sabu from Diabetes India. From Berlin, I am talking to you at EASD. And it's the second day of EASD, rather first day of EASD. Yesterday there was an industry-sponsored symposia. We have with us expert Dr. Sanjeev Phatak from India and Dr. Saidu from United Kingdom. And what we are going to discuss in last 1 day and 1.5 days, how this is going to change our practice. I mean, are you seeing that this new guideline which is going to come release, the ADA had already released, the ADA ESD final guideline which is going to come, is it going to make any difference as far as practice is concerned? Which I will be asking first to Sanjeev and then from our friend who is from UK.
Precisely, Bansi, the new guidelines, which are the proposed ones, the important features are, over a period of time, they are lowering the combination therapy limit. Initially, ADA used to say that any degree of HbA1c you start with metformin monotherapy. Then the guidance came that above 9 you start with combination. And now I think 1.5 above the target they are recommending. Rather, they are going to recommend combination therapy.
So the first thing that this guideline had come with a combination therapy.
Yes, so they are accepting the need for early combination therapy right from the day of diabetes.
But and I think in India we were doing it long back.
Exactly.
What is your experience in UK? How do you do?
So I think my take on the new position statement is not so much emphasis on the combination therapy. It's starting with the patient. Instead of starting with the patient's A1C, you start with the patient themselves. What comorbidities have they got or have they not got? If they've got established cardiovascular disease, then there is a pathway, and if they haven't got established cardiovascular disease, there is another pathway. So depending on what conditions they have, there is now evidence-based medication that you can use to treat them. So for those patients with established atherosclerotic, cardiovascular disease, it is recommended that they they start off with, a GLP-1 receptor agonist with proven cardiovascular benefits, or an SGLT2 inhibitor with proven cardiovascular benefit. If it is a heart failure, the preference is for SGLT2. If it's for ischemic, established cardiovascular disease, then your preference will be a GLP-1. And so I think that is the beauty of it. And when you move to the other side of the algorithm, for patients who do not have established cardiovascular disease, the guideline actually now splits them into 3 categories. Those patients who have weight as a concern, those that have hypoglycemia as a concern, and in areas where cost is an issue. So if you have weight as your main concern, then your options are out of SGLT2, GLP-1, DPP-4 inhibitor, and pioglitazone. And if it is
the pioglitazone, they have not added.
If it's hypoglycemia,
yes,
sorry.
Hypoglycemia.
If it's hypoglycemia, therefore DPP-4, pioglitazone, GLP-1, and SGLT2. If it's weight that's a concern, that is GLP-1 and SGLT2. Fantastic.
But somehow I think the glitazone is being really, what they are trying to show that glitazone is not so useful. While in India we try to use in many patients as a glitazone because it is the insulin sensitizer. So what do you think as a glitazone, positioning of glitazone in this new guideline?
I think it's good because they positioned it wherever you want to use, so long as weight is not your concern, and you can use it anywhere. And indeed, the third arm of the patients who do not have the established cardiovascular disease, they have the glitazones and the SUs are the only 2 for both, the second line therapy and the third line, And for a place like India, I think that would be fantastic. It still has a place. You just have to be careful about the weight gain that you get with fluid retention with pioglitazone. Otherwise, there's still a place for it.
One more thing in Indian guidelines, which we had made in RSSDI, I will send you the copy of it, and that the therapeutic circle, where we had thought of 2 more things which is not included here. One is the age of the patient. When you are having a patient who is above the age of 60 and somebody who is below the age of 60, the therapy also changes. And you would like to become more aggressive in the patients who are younger compared to the patients who are older, which they had also put, but that we had specifically taught. And the second is the glycemic pattern and glycemic variability, which they had not talked here in ADA ESD guideline, while it is there in our Indian therapeutic circle. So what's your comment, Sanjeev?
So, absolutely right, and that's why the AGIs, which deserve a very important place in our Indian patients therapy, because we have a lot of glycemic variability because of our rich carbohydrate diet. We have extremely high postprandial compared to the normal fasting values. And there, I think AGIs are fantastic drugs, and they have been quite successful in India and China, you may be knowing. So I think there is no inclusion of AGIs in these ADA EASD guidelines. So how far relevant they are for our Indian patients, I have some doubts.
Yeah.
Moreover, the benefit of the cardiovascular outcomes has been seen only in the patients who are aged about 65, have BMI less than 30, and have higher baseline HbA1c. But I don't think that it can be generalized to every patient to make it as a guideline that if patient has heart failure, SGLT2 should be the drug which should be preferred. I think there are a lot of other things, including the comorbidities. One most important thing most of the guidelines are still missing is that we still are HbA1c centric or glucose centric rather than being a disease centric. How we treat the other disease, we treat the pathophysiology. And there has been no mention about the pathophysiology of disease in any of the guidelines. I think over a period of
So
time that should come.
pathophysiological approach
Yes.
should be better. What is your experience about the South Asians which you might be seeing in UK population? Because a lot of South Asians are there.
Yes.
So do you treat them with alpha glucosidase inhibitor anytime? What's your experience?
That is
Because
not very
we
popular
do use-
in the
I know
UK.
it's not
yeah.
popular. That's the reason I'm
We
asking.
hardly use them. But yeah, the issue of South Asian population is a very interesting one because the BMI cutoffs, I mean, we've led a
Lesser
lot of
than
work,
that,
is
yes.
a lot lower than the white Caucasians.
And the carbohydrate intake is
Carbohydrate
more.
intake is high, so everything, I mean, they develop more complications at a younger age. So yeah, we are a lot more aggressive with them, and we tend not to worry so much about their BMI. So long as we get the both microvascular and macrovascular benefits, we go ahead and treat them aggressive as we can, and not worry about the weight reduction in those patients.
One last question to both of you. After going back to ESD, I mean, what will be your take-home message to your colleagues? I mean, those who will be working in your country who could not come to this great meeting. What will be your message? I mean, what you thought? I mean, what you will talk to them?
Well, for me, I think the main story will be around the ADA EASD consensus statement.
Right.
Yes, I take your point that there are some issues with it, but it's been very comprehensive, at the very least, for the Western patient.
Perfect.
The Europeans and Americans.
Yes, I agree.
It kind of covers a lot of ground. And you talked about the age and the issue around the intensification. If you look at the first box, that
I know,
circle
that
about
they
that
are given.
patient, there's two goals of treatment. One is avoiding complications, and the other is the quality of life of the patient. So before you start any treatment, before you start prescribing metformin or lifestyle or pioglitazone or whatever, what is your goal of treatment? And that is in the middle. If it's to avoid complications, then you go for your intensification, avoiding inertia and all that kind of thing. But if it is to improve the quality of life of the patient, you may actually be wanting to decrease medications rather than adding more and more and more. And people don't realize that it was intentionally put there for that purpose, so that you don't treat everybody as under age of 60. Patients are different and they have different priorities.
I agree.
Yeah.
Very rightly said. One more thing from this ADASD guidelines was that the inclusion of sulfonylurea ahead of basal insulin or with basal insulin as a fourth drug. I think this is the first guideline which has endorsed or rather recommended that after 3 drugs there is still an option of adding
Using the
sulfonylurea,
yes.
which was never there.
Yeah.
Moreover, from this EASD, there have been several important talks. One of your talk from the technology in diabetes, that was very important. And then prevention of diabetes.
That was
is also, I think, the need of the hour for our Indian patients because the diabetes is becoming rampant in our country.
Good. Thank you. Thank you once
Thank
again.
you very much.
Shadu.
Thank you.
Thank you for
Thank you.